So from Denmark, we're moving to Canada, and Associate Professor Nelly Oelke from the University of British Columbia is going to talk to us about a project facilitating integrated care through primary healthcare teams. Thanks.
The clicker. Do the clicker. Thank you. And I would like to start by acknowledging the traditional lands here and the elders past, present, and emerging. And I'd also like to acknowledge that I live, work, and play on the Silex Nation in the Okanagan. These are my co-authors, a very large team, so I just want to acknowledge them and to let you know that we have academics, patient partners. Our patient partners refer to patients, caregivers, and family. We also have knowledge users and policymakers and decision makers on the research team. So just a little bit about Canadian context in case you're not familiar. We have 10 provinces, 3 territories. This study covers 4 provinces in Canada, 2 in Western Canada, BC and Alberta, and 2 in East Central Canada, which are Ontario and Quebec. It includes our French-speaking province, Quebec, which had some significant challenges for the project. Health is generally led and largely funded by provincial territorial governments, although they do receive some transfer payments from the federal government, but that varies by province and territory. Federal governments largely provide some very overarching services like the Public Health Agency of Canada and services for First Nations communities. All provinces in Canada are regionalized other than Ontario, and Alberta has a single health authority. And Medicare provides funding for physician and hospital services, some home care, and public health. So this study is a policy analysis that focused on policies in those 4 different provinces around primary healthcare teams and how they facilitated integrated care with patients with complex needs. Unfortunately, our number of patients in all countries is increasing with complex needs, and those needs can be both physical and social needs, as we've heard throughout the conference. Team-based care seems to be a prominent model that is often used to address their needs and to improve their patient experience, better coordinate care, improve population health, and also reduce costs. In Canada, primary healthcare teams have been implemented differently in each province, and so hence the mix of different policies. And overall, there still is mixed evidence on the impact of primary healthcare teams on outcomes. We know, essentially that it's the right thing to do, but don't know exactly what the impacts of that are. And then policymakers tend to have little evidence in actually developing policy. These are the research objectives of our project. So we wanted to identify macro and meso-level policies and structures that would facilitate the development, implementation, and sustainability of team-based primary healthcare models with a focus on complex patients. We also wanted to identify macro and meso-level performance indicators used to measure integrated service delivery. We wanted to look at what policy structures, roles, governance, and performance measures supported or acted as barriers to integrated service delivery through patients or through primary healthcare teams. The other 2 objectives focus on involving patient partners in the actual development, implementation, and evaluation of policy, and these we are still working on, and I won't be reporting on those components. We used several frameworks. The first framework was an integration framework that I co-developed with Esther Suter in 2009, and that really is still very relevant today. We also used the principles of the patient medical home. And then we used the policy triangle, where you look at content, context, and processes, and also the actors that are involved in policy, and the relationships between each of those and the complexity of that. So we used a case study methodology for each province being a case. We looked for provincial and regional level policies on primary healthcare teams and integrated service delivery, and had a very stringent inclusion and exclusion criteria. We had 12 policies in British Columbia, Alberta 18, 13 in Ontario, and 15 in Quebec. The one challenge we did have is that we were unable to largely obtain regional level policies, as they were not publicly available for the most part. So we're working currently on writing up the provincial case studies, and then also working on the cross-case analysis. So here are the results. Patient focus. There definitely was a patient partnership in creation of policy, and it was a common theme throughout the provinces. What wasn't clear, though, is that in the implementation and evaluation of policies, how patient partners would be included. And they may be included sometimes as advisory committee members. Policies certainly encourage the actions that incorporate patient-centered approaches, so things like improving care transitions, moving care from community to, or from acute care to community, and also offering services close to home. There was recommendations in a number of the policies that patients need to be provided with information on how to evaluate their own care. And then in our BC policies, there was significant attention to First Nations populations through their work with the First Nations Health Authority. We are the only province in Canada that has a First Nations Health Authority. Standardization of care through teams. Team-based care is a key component of integration for patients with complex needs. There's no doubt about that. Primary healthcare teams include a mix of professionals and skills that are locally responsive and appropriate for the population. We saw recommendations around ratios, 3 to 4 allied health and nursing to 1 physician, although most current teams still have a 1-to-1 ratio. There was no clear direction as to the optimal composition of a primary healthcare team, and I understand that because really your patient needs and your population needs need to drive the composition of your team. The lack of direction, though, in how to do that seemed to be missing. And the concept of the most responsible clinician is outlined in a number of the policies. And that could be a physician, a general practitioner, or it could be a nurse or another healthcare provider. Information systems. Technology and telehealth have the potential to significantly improve access and timeliness of care, particularly for patients who live in rural areas. Electronic health records are key to providing continuity of care and improving communication between team providers, as we've already heard today. Electronic health records have the potential to increase ways to also communicate with patients so that you could have email consultations or different formats of contacting and talking with patients. There are challenges with different incompatible systems, and this is a challenge we have significantly in Canada. Quebec has recently invested in a single system across their province and has also invested in a system, Dossier Santé, which is an information sharing tool between providers. And BC is currently putting more resources into infrastructure. Performance measurement. Overall, there was a lack of focus on indicators and measurement. This is not surprising, and something certainly Nick Goodwin talked about yesterday as well. Provinces who are more advanced in primary healthcare reform have more emphasis on evaluation, and those two provinces are Ontario and Alberta. So in Ontario, we saw policy documents that focused on prevention screening and also compared models within the province. In Alberta, they focused on measuring emergency visits, chronic disease management practices, and medication prescription patterns. And lastly, in this area, performance measurement, functional EHRs that are compatible and can talk to each other are needed for performance measurement. Financial management, fee-for-service funding structures often act as a barrier to quality of care for patients with complex needs. It's not designed to incentivize preventative and proactive care. Team members were sometimes reluctant to take responsibility for patients with complex needs as the most responsible clinician. And so you had this effect of a hot potato where the patient was transferred from one provider to another with really not one person designated as accountable and responsible. Remuneration models are not addressed and are often counterintuitive to team-based care, like fee-for-service models. Finally, team-based care has the potential to increase patient and provider satisfaction. So primary healthcare teams are essential in improving the outcomes for patients with complex needs. Policies can provide a framework for action for these primary healthcare teams and integration. We need to have direction on patient-centered care approaches, less on how patients should be, and that we need to ensure that patients are involved in implementation and evaluation of policy as well. There's a lack of direction on the composition of teams and remuneration models. Essentially, that is left untouched in our Canadian landscape. We need strong support for EHRs and technology. Implementation and infrastructure and funding for the same does vary. And performance measurement needs significant attention. And we need to attend to the unintended consequences of policy that may arise and are important to recognize. So if you do one thing, it may actually then impact something else. So what were the limitations? We didn't get regional level policies. We're missing the input of policymakers to clarify questions and provide additional information. The complexity of the project in of itself may impact the depth of analysis. It provides a snapshot in time. Changes in government can result in significant changes in policy. Ontario had a new government a year ago and has changed up the whole primary healthcare system. So that will not be captured, unfortunately, in this analysis. Despite the limitations, our policy analysis can provide important information for policy and decision makers to improve integration through primary healthcare teams. Lessons learned, policy analysis is complex and challenging. It isn't for the faint of heart. Patient engagement in policy development is evident. We need to ensure that they are included in the entire process. Significant work is needed in performance measurement around teams and integration to understand the impacts on outcomes. We need to address remuneration models. Identifying unintended consequences is important so that we can address those issues. And how do we present the results to so that they are relevant to policy and decision makers? And that has been a real challenge because we talk such different languages. And then far more work is needed around policy analysis to actually better understand the same. And our research is timely because we have continuing primary healthcare redesign, as I said, in Ontario, in Canada, and internationally. And our results have the potential to provide a good foundation for policy change in participating provinces nationally and internationally. Thank you.